Well, it's been a long day for most of you, and thanks very much for sticking up to the last speaker. I'll try to do my job in very quick time, and then for questions, maybe we could do it on an individual basis because everyone is tired. We started the Division of Biomedical Informatics at UCSD last year. And I would like to present a couple of things that we've been doing that might be less obvious to the world than what is usually known as bioinformatics. So I stick to the biomedical because there's a lot of clinical work also been done in this field. So let me try to make this work here. Where is the keyboard right there? Okay. Oh, thank you. Okay, thank you. So it's an intersection of fields, and for this audience, I do not need to emphasize the importance of interdisciplinary work. So I think I'll go very quickly on here, just to emphasize that as any other clinical division in the School of Medicine, we have three missions. One of them is the clinical mission, the other one is research, and the other one, education and training. So I decided to do a little overview of these three with particular emphasis on the ones that you might not be very aware of. We have two homes, one in the Supercomputer Center and the other one at the School of Medicine. So here's how we are organized. In clinical, as you see, it's in italics because the clinical portion of informatics is different than serving the patients directly. It's actually serving investigators and clinicians in order for them to do a better job. We have several areas. One of them is clinical research and also instrumenting research for the health sciences as a whole. This is funded by a CTSA grant from the NIH. And we have clinical tools, so clinical decision support tools, clinical improvement tools that I'll show next. And a variety of initiatives, including one nascent now, to connect all the clinical data warehouses of 5 UC medical centers. This will be a very, very powerful source of data for research and for quality improvement. Our research, I didactically put in foundations and applications because there are several pieces of work that make us build better applications for clinical and research use. And these include natural language processing, privacy technology, so that your data doesn't get disclosed to unauthorized people, imaging informatics, and data mining and predictive tools, predictive models that we do on this large collections of data. And obviously, being in the university, we have the educational mission, and we divide that into national and international. We have a large portion of our projects outside of the United States. So in terms of clinical research and collaboration, we like to aggregate data to monitor safety of medications, procedures, devices, measure quality. So if we measure, there is a hope that we can intervene and make it better. Enable comparative effectiveness research and improve process and communication with telemedicine. This is a case study that I shortened considerably for this audience, but this is a fatal case that happened in my previous institution. And it is a result of a cath lab procedure. So when the auditory is full, I could estimate the number of people here who would have a heart attack, would end up in the cath lab. There are very few people here, but at least 5 here will experience that unless we do a better job in medicine, preventive medicine. But assuming that that's the case, why do these complications still happen? Is there something we could do about it? This is a very important one. It's internal bleeding that happens during or after the procedure. In this case, it was after, 4 hours after. So there was a hypothesis at the time that the vascular closure device, a particular device, could be implicated in these complications. The problem was that the hospital was using this device in 82% of the patients. So if it was implicated in a higher complication rate, that would be an important thing to know. How do we know about that? how do we know that these complications, which are at a 0.5% rate, very low rate, are increasing if you have one or two more? So you need large numbers of data in order to be able to detect those problems. And fortunately, we had constructed a database over time of all procedures happening in that hospital. It was a high-volume academic affiliated of Harvard Medical School. And we were able to take a look at whether closure device was implicated or not. We built a software tool to track new devices over time. You remember stents in coronary disease. They are being recalled once every couple months. So we wanted to detect those earlier than what's currently the case, which is voluntary notification to the FDA. So you only get things recalled after a large number of this voluntary notifications. So that is a problem. If we can monitor our own hospital of what's going on there, we can detect these problems earlier. So this was done, again, in my previous institution. We, a colleague of mine, Dr. Rasnek, led this project, and it's an aggregation of data from 3 different places in there for cath lab procedures in order to detect abnormalities and complications. So in here you can tell that you had the opportunity to notice with a statistical process control algorithm that even though the rate went up from 0.5% to 0.6%, that was an abnormality, and that was not happening just by chance. Upon review of the cases, it was noticed that the culprit was not the vascular closure device. That is the last row there, and so the p-value is not significant. It was not the cause of complications. What was really the cause is the site of the puncture. It was happening above where it's supposed to be, which is where the arrow indicates now. And in some of the cases, it occurred above that. So that's a problem that could be corrected with better training of the operators and minimize and get the process back in control. So that was done and resulted in good outcomes. So we learned from that the tool was very helpful in detecting the event, but after you detect, you have it actually to come back and get the causes so that you can influence. So fewer people will have this complication. It's unavoidable, but you can keep it under the reasonable control. And we did that for operators too. Fortunately, none of them was out of the control, and we could detect that everyone was having good outcomes. So now we're changing the face of medicine with new genomic tools and new variables that we can enter in these predictive models. How is it affecting clinic these days? Not much, but it will. And the issue is, are we prepared for it, and how are we preparing for it? So in a recent funded project, we are monitoring the safety of new medications. So the goal here is exactly the same as monitoring the safety of devices. Are these new medications any safer than the ones previously? Do they have better outcomes? Is it significant? So we are partnering with Harvard hospitals as well as Vanderbilt and the VA and UCSD and collecting this data in order to realize if the Plavix substitute is any better and with fewer complications than the original drug, and the new drug that is supposedly substituting warfarin is going to be safe and it's going to be better. So this, again, requires a lot of data collection. The moment you start collecting genomic data, you increase the number of variables significantly, and therefore you have to accompany that with a significant increase in the number of cases. So that was essentially one of the examples of our clinical applications. And the other ones are also related, and there are research projects for each one of the foundations or applications that I mentioned. And instead of repeating all of them here, let me just say a couple things of the ones that are less popular or less well known. One of them is for privacy technology. Can we develop anonymization algorithms, de-identification algorithms, that we then can share this data with others, so they too can build models and build better models, and we can share data across the globe, so we can detect these patterns much faster than what's happening right now, which is several years until we know a particular medication causes heart attacks, and then we have to withdraw. How many people die before we know that? So that's an implication of this. So the new center that we got funded here at UCSD by the NIH is the National Center for Biomedical Computing, and several schools were involved. Dr. Patrick, who's in the audience, is leading one of the cores in this center, which is for integrating data for analysis, anonymization, and sharing. What do we want to do? So we are now one of the new centers, actually the only new one funded this cycle. And we want to do privacy, we want to apply privacy technology so we can really share data so others can mine that data and find patterns too. And by doing predictive models and data mining, we can probably achieve something closer to personalized medicine than what is done today, which is one-size-fits-all medicine. There are several schools involved, as well as our partners. It's a relatively large grant from the NIH, and we have just started. We're 2 months into the project right now. What is it about? So data today, how are data shared, if at all? There are public repositories. These are mostly biological data, no clinical data in public repositories at this moment, and they are very restricted. And the fear is that if you disclose the data, they will know who you are and what diseases you have, and this might have insurance implications and other things. So by constructing privacy technology tools, we will ensure that this cannot happen to a reasonable degree. So tomorrow we see a lot of public databases, de-identified, anonymized, that others could use. There is also a scientific computing divide between those who have computational resources and those who don't, especially resources that are needed to process high volumes of genomic data, such as the whole genome sequences that are coming to be very cheap in the next few years. So how can we share also our computational resources so people with good algorithms, good ideas, can also have access to the computational power and the data that they need to evolve and to develop better methods. So what we envision in the future is, just as the Human Genome Project was organized across several institutions, the whole detection, monitoring of safety could be developed across several institutions. And that's why we're building infrastructure for that, integrating data from different biological levels, anonymizing the data, including anonymizing for which institution provided the data, so that you can't use that for a competitive advantage across institutions. Data analysis and the large volumes of data, how can we compress, how can we query on compressed data, and then extract value from that in the high-performance computing algorithms that are needed, and then share that with users inside the UCSD, outside, and anywhere in the country. The cyber infrastructure, you heard about that from Ingolf Kruger this afternoon, so I won't belabor on that. It's an architecture that isolates the data from the processing from the management zone, is very well designed. And we're using this for a variety of projects. And so instead of repeating all here, I would just say one of them is Kawasaki disease. It's a rare disease that occurs in children. It's a cardiovascular, it's the highest cause of cardiovascular acquired disease in children. And it's a rare disease. So unless you aggregate data, you won't find much meaning in particular studies, and that's what we're doing here with Dr. Jane Burns, who's been studying this disease for 35 years and has one of the largest databases for it. So we're doing microRNAs and a whole lot of other studies with it. Greg Norman from here, from CalIT2, is another biological project here, and he's studying sedentary behavior. So how accelerometers and other types of sensor data can inform interventions that will allow people to be more active and less sedentary. We also have, as part of another project, a scalable network for comparative effectiveness research, which is connecting data from several sites in order to do the comparative effectiveness of medications and also some interventions. There are a lot of partners in this other project, and the goal is to build then the network. So in the other project, we're building where the data sits and the use of computational resources, and this is how we build a certified, authenticated network, so we know who is requesting data, whether the person is authorized or not. Training, we have several initiatives going on, and we want to expand those to here. We have a collaboration with Mozambique, the Maputo Central Hospital, and we are enabling that to talk to São Paulo, Brazil, because it's the same language, Portuguese language. So this is the summary of our activities here. Each one has some sources of funding. The letters there are mostly NIH support. And it was to give you an overall idea of what biomedical informatics is doing. You usually think of the molecular level bioinformatics, but there's a lot of clinical activity going on, and that depends on data and processing of the data. So I just want to acknowledge the people involved with this and many collaborators as well. And I end with a tagline, as others said, doctors without borders. We can do informatics without borders as well. So thank you.